Hello dear respected students, today we are starting new topic, valvular heart diseases. You know, heart has three layers. Main layers are endocardium, myocardium and pericardium, and also this endocardium is the inner lining of heart, which is similar in structure to the wall of blood vessels. Surface of endocardium is formed by a single layer flat endothelium, which is characterized by a unique smoothness since its direct contact with blood. Also, the big thick layer is myocardium, and pericardium has two parts, this visceral part, epicardium itself, and parietal pericardium, between them pericardial cavity. Today we will focus on endocardial damaging. Also, you should know that leaflets of heart valves are formed by double fold of endocardium. That's why endocardial damaging always result in damaging of valves. For example, endocardial may damage because of infective endocarditis or rheumatism. Also, endocardial damaging may result in damaging of vessels because endocardium, this is continuum of endothelium of vessels. There are two types of valvular heart disorders, stenosis and regurgitation. In stenosis, inflammatory process cause conglutination of leaflets of valves, which result in formation of small hole when our valve couldn't open properly. Regurgitation. In regurgitation, inflammatory process cause damaging of borders of leaflets of valves, and which result in shrinking of these valvular leaflets, and when valve doesn't close properly. Main reasons of regurgitation are congenital rheumatism, infective endocarditis, syphilitic aortitis, valve ring expansion, valve rupture, senile degeneration, and damage to the cord and papillary muscles. Main reasons of stenosis are congenital rheumatism and senile degeneration. Here is types of valvular heart disorders: mitral valve defects, aortic, tricuspid, and sometimes pulmonic, but in most of cases pulmonic valve defects may be secondary. Uh, all these valvular defects may be or stenosis or regurgitation. Also, we are recognizing two types. Another two types is associated and combined. Associated valvular heart disease, when in one valve we have presenting of stenosis and regurgitation. For example, your patient has mitral stenosis and or plus mitral regurgitation. Combined defects, when in one time we have presenting of defects of two different valves. For example, mitral stenosis plus aortic regurgitation. In most cases, mitral and aortic valves are affected more often than others. You see mitral valve diseases on the first place. It takes from 70 to 75% of all cases. Aortic valve diseases on the second place, 8 to 10%. Tricuspid valve defects is very rare, from 6 to 8%. And combined pathology of mitral and aortic valves takes from 10 to 14%. To clear understand hemodynamic changes of hemodynamic changes in valvular heart disorders. Of course, you should remember normal circulation, and also remember Chambers pressure. Let's start from mitral stenosis. Mitral stenosis mostly caused by rheumatism, infective endocarditis, and calcification. Area of mitral valve is 4 to 6 square centimeters. Symptoms starts when this area become to be less than 2 square centimeters. Let's discuss about pathogenesis or mechanisms of development. Obstruction to left ventricular inflow at the level of mitral valve due to structural abnormality of the mitral valve apparatus cause decreasing in area of mitral opening. That means that causes systolic overload of left atrium. Overload of left atrium cause increasing systolic pressure, which in normal condition not more than 8 millimeters Hg. At the beginning time, of course, it will be compensated by hyperfunction and hypertrophy of left atrium, but day by day develop myogenic dilation and increasing pressure in pulmonary veins. Increasing pressure and overloading of left atrium automatically can increase pressure and overloading of pulmonary veins, and overloading of pulmonary veins induce the activation of Kitaev reflex as a response to overloading of pulmonary veins. We have develop spasm of pulmonary arteries, which cause pressure overload of right ventricle and right ventricular hypertrophy and its myocardial dilation, myogenic dilation. Of course, during palpation percussion, you can find out enlarging of the left atrium and right ventricle, but enlarging of left atrium and right ventricle may be caused by another reasons, not only by mitral stenosis, valvular heart disorders. That's why the main diagnostic criteria to detect the valvular heart disorders and to suspect the valvular heart disorders, this is auscultation phenomenon, this is murmurs. That's why on the first place, valvular criteria, this is main criteria. On the apex, you can find out accentuated S1. Sclerotic valves in mitral stenosis formate the high-pitch S1 sound, and also may be heard opening snap of mitral valve and diastolic murmur. Types of diastolic murmur may be presystolic and mesodiastolic murmur. And also present indirect criteria you can find out during investigation: right ventricular hypertrophy, left peristernal heave during palpation, and precordial and epigastric pulsation, expansion of the absolute dullness of the heart, left atrial hypertrophy, shift upper border, and also you can find out mitral configuration. Pulmonary hypertension appear by shortness of breath, cough, in severe cases hemoptysis. Also during inspection you can find out mitral phase, pinkish purple patches on the cheeks. This mitral phase develop due to very high pressure in pulmonary artery, which associated with a low cardiac output. And during auscultation you can find accentuated S2 on pulmonary artery because of increasing mean pulmonary pressure more than 25 millimeters Hg. Here you see, of course, diastolic murmur. This is main criteria. You see accentuated S1 sound, high pitch S1 sound, and then S2. Then you see opening snap. You can auscultate opening snap and diastolic murmur. On ECG, you can find out left atrial and right ventricular hypertrophy. Also, this valvular heart disease can result in atrial fibrillation. This is main complication of this mitral stenosis. Atrial fibrillation may be seen on ECG, and you see instead of P wave there are many small waves. This is waves of atrial fibrillation. In case of atrial fibrillation, extremely decrease pressure near the wall of left atrium, which cause formation of better condition to thrombus formation, and this thrombus can formate the embolism and can attached from the wall and go to the systemic circulation and cause blockaging of different kinds of vessels and cause, for example, brain stroke. This is a main complication of this mitral stenosis. On ECG, you see left atrial hypertrophy signs, enlarging of P wave, enlarging of P wave more than 0.12. Also, you see increasing deepening of the negative phase on V1. This is left atrial hypertrophy signs. Right ventricular hypertrophy signs, you see right axis deviation, increasing R wave on V1, V2, also signs of right bundle branch blockages, and deepening of S wave in V5 and V6. If you get algebraic sum of R wave in V1 or V2 plus S wave on V5, V6, it will be more than 10.5. And also you see ventricular activation time on V5, V1 and V2 more than 0.03 seconds. X-rays shows backward displacement of esophagus by enlarged left atrium in lateral view, enlarged left atrium, double shadow due to enlarged left atrium, straightening of the left heart border, splaying of carina left main bronchi in lifted up by the enlarged left atrium, prominent upper zone pulmonary veins, inverted mustache sign or antler horn sign, cephalization of pulmonary of blood flow, and curly bill lines indicating fluid collection in the interlobular septus. On X-ray, if you remember, there are 4 arches on left side and 2 arches on right side. 4 arches, first arch, this is aorta, second is pulmonary artery, third is left atrial appendage, and fourth is left ventricle. In these cases, of course, we can enlarging of left atrium. That's why this is formatted mitral configuration of heart. And of course, also you see enlarging of pulmonary artery. On the right side, you see this is vena cava superior arch and right atrial arch. On these cases, of course, we can enlarging of absolute dullness because of enlarging right ventricle, and of course this is right side will be shift to the right border will shift to the right side. Gold standard of mitral stenosis or any other valvular disorder, this is echocardiography picture. Echocardiography shows valve domes in diastole due to chemocerebral fusion, leaflet thickening beginning at the edges of the leaflets, produces significant narrowing of orifice. For example, here you see a significant narrowing. Mitral valve area is 1.6 square centimeters instead of 4 square centimeters. Clinical picture depends on severity of narrowing of mitral valve. You see normal mitral valve when area 4 square centimeters, moderate mitral stenosis when square less than 4 and more than 1.2 square centimeters, and severe mitral stenosis when area less than 1 square centimeters. There are stages of mitral stenosis. First degree disease is fully compensated, and second degree when signs of circulatory disorders in a pulmonary circulation detected during exercises only. Third degree pronounced signs of circulatory disorders in pulmonary circulation in a systemic circulation initial, and fourth degree pronounced stagnation in the systemic circulation and formatted atrial fibrillations, and grade 4 when developed dystrophic processes in heart and which result in congestive heart failure. Complications of mitral stenosis. Of course, as you mentioned before, this is atrial dysarrhythmias or atrial fibrillation, systemic embolization, risk related to age, presence of atrial fibrillation, history of emboli of cerebral arteries. It's about 60%. Hemoptysis due to rupturing of bronchial pulmonary veins, chronic bronchitis, acute pulmonary edema, and pulmonary infarction. Congestive heart failure, this is also complication, and recurrent bronchopulmonary infections sometimes may be complicated by pulmonary hypertension, of course. Next is mitral valve regurgitation. Main causes is rheumatism, atherosclerosis, protracted septic endocarditis, and heart injury. Mitral valve regurgitation, this is incomplete closure of mitral valve leaflets during systole. During systole blood should go to the systemic circulation, but in case of incomplete closing, blood also may go opposite to the to opposite direction to the left atrium, which causes the overloading of left atrium, and during diastole phase, blood goes to the left side, and also we have overloading of left side. That's why in this regurgitation we have overloading of left atrium as well as left ventricle, which cause a tonerogenic dilation and left ventricular hypertrophy. Diagnostic criteria, of course, on the first place, this is auscultation phenomenon. At the apex, S1 is weakened because in insufficiency of mitral valve, this mitral valve couldn't formate a normal S1 sound, and also rough systolic murmur, which is adjacent to the first tone. Systolic murmur, it means this murmur will be heard between the first and second sounds. Indirect criteria is left ventricular hypertrophy, enhanced widened apical impulse because of enlarging of left ventricle, expansion of the border of the heart to the left side. You can find out during percussion, expansion of the fourth arch on X-ray. Left atrial hypertrophy, it'll be found by expansion of superior border, upper border of heart during percussion, mitral configuration, and expansion of the third arch on the left on the X-ray, and pulmonary hypertension. Instrumental examinations, ECG shows you left atrial hypertrophy and left ventricular hypertrophy. On this ECG, you see left atrial hypertrophy enlarging of P wave on the second and first leads, and deepening of negative phase on V1, and left ventricular hypertrophy signs. You see left axis deviation, increasing R wave on V5 and V6 with the deepening of S wave in V1 and V2. And if you combine S wave plus R wave on V5, V6 and S wave on V1, V2, it will be more than 35 millimeters. If your patient is old, plus 40 years old, if your patient is young, it will be more than 45 millimeters. And also you see ventricular activation time on our left side leads V5, V6 more than 0.05. Echocardiography, this is gold standard to diagnosis of all valvular disorders, and mitral regurgitation is not exception. Mitral regurgitation on echocardiography shows by leaking of complete closure of mitral valve in systole, dilation of the left ventricle. Also Doppler ultrasound shows you mitral regurgitation grade. For example, here is third grade of mitral regurgitation. X-ray shows you mitral configuration of the heart, deviation of esophagus along an arch of a large radius in lateral view, and also may shows you pulmonary hypertension or congestion. Next is aortic stenosis, mostly caused by rheumatism, infective endocarditis, sclerosis, and syphilis. Area of aorta in normal condition 3 to 4 square centimeters, and on this picture you see extreme aortic stenosis when this hole is even less than 1 square centimeters. Of course, left ventricle has to pump blood through this narrow hole to the systemic circulation. Of course, to systemic circulation goes very less blood. Narrowing of aortic opening cause the pressure overload of left ventricle. Even this pressure gradient between the left ventricle and aorta become to be more than 40 mmHg, and pressure overloading of left ventricle cause left ventricular hypertrophy, and even may cause the left ventricular failure. When develops left ventricular failure and dilation of left ventricle, this can cause the increasing or enlarging ring of mitral valve, and we call this phenomenon as mitralization of aortic valvular disease. When develop mitralization, also increase pressure in left atrium, and may also increase pressure in pulmonary veins and then arteries. And diagnostic criteria, of course, on the first place, this is auscultation phenomenon because of aortic damaging, aortic valve damaging. We have weakening of S2 on the aorta, and formatted rough systolic murmur above the aorta, extending to the vessels of the neck, to the jugular and subclavian fossas. At the apex of heart, S1 is preserved. Indirect criteria: left ventricular hypertrophy, enhanced diffuse apical impulse, displaced to the left and downward, and aortic configuration of heart. Additional criteria: pallor of skin because of decreasing systemic pressure, decreased pressure, you see systolic, decreasing pressure may be decreased as well as systolic and diastolic pressures less than 100 millimeters. The severe stenosis, the more decreased pressure in aorta. Systolic tremor cut per in the second intercostal space on the right and in the jugular fossa. Arterial pulse is small, slow, systolic blood pressure is reduced, dizziness, fainting, pain in the region of heart and behind the breastbone. Why our patient feels pain? Because of course, a decreasing pressure in coronary arteries, because decreased pressure in aorta cause decreasing pressure in coronary arteries and decreased blood supply of myocardium at the first place. On the second place, of course, because of left ventricular hypertrophy, increased demand of heart, and we have here two mechanisms of chest pain, because chest pain, this is representative of ischemia of myocardium, and sometimes develop pulmonary hypertension. Aortic stenosis course is for prolonged time. Aortic stenosis may be asymptomatic. This asymptomatic stage may prolong even till more than 25 years. But when started or onset of symptoms, this onset of symptoms may be represented or by angina or syncope conditions or chronic heart failure. If develop of these symptoms, mortality exceeds 90% within a few years, only few years, and aortic valve replacement prevents this rapid downhill course. That's why it's very important to diagnose this aortic stenosis before developing these symptoms and do replacement therapy. ECG shows you left ventricular hypertrophy signs. You see on this ECG left ventricular hypertrophy signs as a left axis deviation, also increasing R wave on V5 and V6, deepening of S wave in V1, V2, and also you see ischemias or repolarization processes on V5 and V6, or left leads first AVL and V5 and V6, and enlarging of ventricular activation time in left leads V5 and V6. Echocardiography shows fibrosis of the aortic valve leaflets, decreasing the amplitude of their systolic divergence. On this picture you see first S1, S2, between them crescendo, decrescendo, rough systolic murmur. X-ray shows you heart of the aortic configuration. Waist of heart is emphasized because of enlarging of fourth arch, enlarging of left ventricle, and also ascending aorta is enlarged. Sphygmogram shows you a form of a cock-comb due to decreasing pressure, in systemic circulation. Complication is left ventricular heart failure, pulmonary edema, conduction disturbances, left bundle branch blockages, complete AV blocks. Next is aortic regurgitation, mostly caused by rheumatism, prolonged septic endocarditis, syphilis, sometimes may caused by diffuse connective tissue diseases, atherosclerosis of aorta, and very rare blunt chest traumas, and etc. Aortic regurgitation, incomplete closing of aortic valve during diastole phase, reverse flow of blood from the aorta into left ventricle, and cause overloading of left ventricle. Left ventricle diastolic volume overload, and as we have increased ejection of blood into the aorta, because left ventricle during diastole will filled not only by left atrium, also by outflow blood from the aorta, and we have increasing systolic pressure and low diastolic pressure, because half of blood will go back during diastole phase. And in this, for this aortic regurgitation character, first increasing systolic, very high systolic pressure, for example 180, and very low diastolic pressure, for example 50, when pulse pressure become to be very high, or sometimes maybe 180 to 0, even you couldn't detect the diastolic pressure. Diagnostic criteria: on the first place, of course, this is the auscultation phenomenon, weakening of S1 on the aorta, and diastolic murmur, especially in Erb's point. Also, you can distinguish by palpation and percussion signs of left ventricular hypertrophy, wide pulse pressure, increased systolic and decreased diastolic pressure. Wide pulse pressure, for example, 140 to 40, and pulse pressure will be 100. And all these peripheral symptoms, and all symptoms connected with increasing pulse pressure. Peripheral symptoms like pallor of skin, fainting, dizziness, nasal bleeding, shortness of breath, palpitation, chest pain, and also some symptoms, character symptoms, specific symptoms like carotid pulsation, Corrigan signs, when pulsate the carotid arteries because of very high pulse pressure, and Demussier's sign, head nodding with each heartbeat, also because of a big pulse pressure, and Quincke sign, capillary pulsation in nail bed. And also there are very different specific symptoms like trope signs. This is pistol shot sound over the femoral arteries. This trope sign is a sound phenomenon when two tones are heard on a large artery, for example femoral or brachial artery. Austin Flint murmur, this is mid-diastolic murmur over the cardiac apex. You know, on cardiac apex will be heard on the mitral valve, and diastolic murmur of relative functional stenosis of the left atrioventricular opening, mitral valve, which is occasionally heard in patients with organic insufficiency of the aortic valve. Mechanisms of occurrence is displacement of the anterior cusp of mitral valve by a stream of blood regurgitating from the aorta into the diastole, which creates a narrowing of the mitral opening resembling mitral stenosis. That's why it will be heard diastolic murmur on the apex. And Durosia sign, double murmur of Durosia, is heard over the femoral artery in the groin area directly under the pupil ligament. Systolic murmur occurs when the stethoscope heard in gradually pressed due to the artificial occlusion of the femoral artery. Diastolic murmur, quieter and shorter than systolic murmur, occurs with further compression of the femoral artery. ECG shows you signs of left ventricular hypertrophy, also signs of left atrial hypertrophy in case of mitralization, and left bundle branch blockages. X-ray, elongation of fourth arch, you have elongation of left ventricle, aortic configuration of heart with a significant displacement of the apex to the left, angle between the vascular bundle and contour of left ventricle become less obtuse and the waist of heart more emphasized, and post-stenotic dilation of aorta. Echocardiography in M mode shows diastolic tremor of the anterior cusp of mitral valve, which occurs under the action of reverse turbulent blood flow from the aorta to the left ventricle, incomplete closing of aortic valve cusp in diastole, and Doppler echocardiography shows regurgitating blood stream from the aorta, and rate of blood flow regurgitation is determined by the pressure gradient between the aorta and left ventricle. Sphygmography shows if in normal condition in first picture in aortic regurgitation shows when arterial pulse become fast, high, large, and fast. We call it in Latin pulsus celer, altus, magnus, et frequens. Of course, in treatment of valvular heart disorders, we should use valve reconstruction and valve replacement. All indications and contraindications you will study this surgery class. Thank you for your attention.